Hi everyone, this is Kyle, and I'm going to be presenting on the PA projection of the wrist, as well as the PA external oblique of the wrist. For clinical indications for a PA or an AP wrist, it's going to evaluate for fractures of the radius or the ulna, as well as fractures of the radial or ulnar styloid processes. Since we are focused in the carpal area, it's not a shocker that we're going to see fractures of the carpal bones. Now, of those 8 carpal bones, the most likely you're going to see visualized in a fractured situation is going to be the scaphoid. And in terms of pathologies, you're going to see a patient with osteomyelitis or arthritis. Now, for technical factors to set up for a PA wrist, your SID is going to be set at 40 inches. Your IR, if you have the ability to change it, is going to be at a size of 8 by 10 inches in the portrait format to take advantage of the long axis. Now, there will not be a grid. The anatomy is quite small and what you're focused on, and also your KV range is going to be at 55 to 65. 55 to 60 is pretty appropriate, so doesn't feel like there's much of a need to go any higher, but you can go up to 65. Now, it's good practice to use a lead apron or shield the person in areas that are outside of that region of interest. So, because of the way the patient's going to be positioned, it's not uncommon for that tissue of the lower extremity to get any residual dosage, even if it's very minor and very small. It's still just good practice to put that lead apron on them, on their lap specifically. Now, for centering, your CR is going to be perpendicular to the image receptor. There will not be any angle, so you're going to direct that CR to the midcarpal area. From there, like I said, it's a small amount of anatomy. You're going to collimate on all 4 sides. Now, you're going to collimate from the distal radius and the ulna all the way to the mid-metacarpal area. For positioning purposes, you want to align and center that long axis of the hand and the wrist to the image receptor with that carpal area in the center. When you're doing a PA, the hand that's going to be pronated, you want to arch that hand slightly so that you're placing that wrist in that carpal area in close contact with the image receptor. This isn't really as much just for magnification purposes. This is also to help minimize the superimposition that you're going to see in the distal radius and the distal ulna that is going to show up on the bottom half of the carpal bones, like the lower scaphoid region. Now, for patient positioning, your patient's going to be seated at the end of the table with their hand and their forearm extended. When that happens, you want to drop their shoulder so that the shoulder, the elbow, and the wrist are all aligned on the same horizontal plane. Now, this is a positioning video that we have. It's of Selena positioning tuba for a PA wrist. Now, I would go over the whole video, but as I know from watching it, Selena did follow all the technical factors. She did everything correctly. And I also know that Selena takes good x-rays. So I'm not going to go over that. Instead, we're going to talk about the anatomy and the anatomy of a image we took on a phantom. So as you can see, the criteria you want to meet is to have that mid-metacarpal area and that proximal metacarpal region. You want to see the carpals, obviously, and then your distal radius and your distal ulna. You want to have those visualized as well as the associated joints with them and the pertinent soft tissues of that wrist joint. So you want to see those fat pads that you'd see on this left side here, or the fat strips as well. They're going to be visualized if this wasn't a phantom. And then in terms of in the carpal region, all the intercarpal spaces that you're seeing here, they're not all going to appear open because of the irregular shapes that are resulted from the overlapping structures. So it's not going to be common for you to see all of these spaces open. You're going to see a couple open, but don't bank on getting them all open. Now, for positioning purposes, you want to have your long axis of your hand, your wrist, and your forearm to all be aligned with the image receptor. If you are performing a true PA, it's evident by the equal concave shapes that you're going to see on each side of the shafts of the proximal metacarpals, as you see here. You're going to have near equal distances that's going to exist among the proximal metacarpals, and then separation of the distal radius and the ulna is going to be present except for the possible minimal superimposition at the distal radial ulnar joint spacing right here. Now for CR and center, your CR, the center of it and the center of your collimation field should be in the mid-carpal area, so it should be up here. We're about an inch to inferior. So if we just go up about an inch, we'll be around exactly where you need to be. And then for exposure purposes, this is pretty consistent throughout most exposures, but you want to have your optimal density or your brightness. You want to make sure that that contrast is visualized well with no motion. You should have your soft tissues visualized with your pertinent fat pads. You want to have your sharp bony margins of the carpals to be visualized with clear trabecular markings as well. Now moving on to the PA external oblique. It's the same clinical indications. You're going to see a fracture of the distal radius or distal ulna. You're going to see isolated fractures of the styloid processes. And of course, you're going to see a fracture, if there is one, in the carpal bones. Pathology will also be the same. Osteomyelitis and arthritis will be the most common ones to see for technical factors. And your shielding, your technical factor is going to be at 40 SID again on an 8x10 if you have that choice to switch it. Otherwise, tight collimation. No grid still. Your KV range is going to be from 60 to 70. 60 is just fine. And then, of course, as I said before in the earlier slides, shielding any of that radius-sensitive tissue that's outside the region of interest. So someone's lap is positioned right under the table. Just put a lead apron on if you want. Why not? What's the harm? For centering, your CR is going to be perpendicular to the image receptor again. You're going to direct that to the midcarpal area, and then you're going to collimate from the distal radius and the distal ulna to the mid metacarpal, at least on the top and bottom collimation sides. Now for part positioning, you're going to align and center that hand and wrist to the image receptor. From a pronated position, you're going to rotate that wrist and hand laterally to about 45 degrees. It's a pretty slight alteration. It's very easy to achieve 45 degrees with a hand or wrist. So keep that in mind. Now for stability purposes, if let's say the patient cannot do it very well on their own and you have to put them in an oblique position, you want to place that 45-degree support or sponge under the thumb side of the hand and allow it to support that hand and wrist in order to best elevate it in the position that you need. Patient position is going to be the same though. The seat is going to have the patient at the end of the table with their hand and forearm extended out, and then their shoulder is going to be aligned with their elbow and their wrist on the same horizontal plane. Now, Selena once again was showing how to do this on tuba. As you can see, Selena does a little bit of obliquity and then she puts her hand there just to make sure she's not overdoing it. But as I said, she's good at what she does. I don't need to go over everything. We know she can take x-rays. Now, talking about the anatomy for a PA external oblique, your distal radius, ulna, your carpals, and at least you're going to have all of that to the mid metacarpal area visualized. Now, your trapezium and your scaphoid should be the most visualized or well visualized with slight superimposition of the other carpals on the medial aspects. So these bones are overlapping right here. So your trapezium has your trapezoid overlapping slightly here. Your scaphoid has your capitate and your hamate slightly getting over here. Now, for positioning purposes, your long axis is going to be the same way. The long axis of that hand, that wrist, and that forearm is going to be aligned with the image receptor. For a true oblique, it's going to be 45-degree oblique of the wrist. That's evident by the ulnar head being partially superimposed by the distal radius. Proximal third through fifth metacarpals should appear mostly superimposed. So you should not really see them well visualized. They're going to be kind of overlapping pretty good. And then a CR and center of collimation field should be to metacarpal area. So as you can see here with the centering, go up about a ½ inch and you will be right where you need to be on that medial aspect of where the scaphoid is right here. And in terms of the ulnar head being partially superimposed, you can see the ulna right here. It's pretty partial. Could be probably a little less obliquity on the phantom, but obviously it's a phantom. It's a little bit more challenging to achieve, making those tiny micro adjustments. In exposures, you're going to have your optimal density and your contrast. You don't want to demonstrate any motion, and that's evident by the carpals and their overlapping borders looking the way they do with those sharp bony trabecular markings. Obviously, making sure everything is nice and neat looking.